So today's session, as I said, is about innovation, and essentially what we're going to be talking about is this concept of innovations and the future. And so there are a number of questions that you now have if you have been able to log in. And the two specific questions that we're going to talk about is when you think about industry, so we're all in the healthcare industry, but what might be some other industries that you think of as being innovative? And if you were to vote for the most innovative industries, which would be the industries that you think about as being innovative? So I know that there's a little bit of a delay here. It says no votes have been cast. Biotech, technology, look at us.
Very good.
Come on, health services, let's go. Okay, no. Excellent. So it looks like the runaway hits for us are technology and biotech. And then coming up behind that is healthcare. And then, yes, health services. And then education and health systems management. So when we think about innovation, what is it about these industries that we say makes them innovative? And so that's going to be part of today's discussion. The next question which we're going to have, and you should see it within your app, is a question in terms of promoting innovations. And so you'll see that question, but we'll get to it later on. So let us move over here, or I'm going to move over here, and face our panel. So the first question is, what is innovation? So before we were starting today's session, I actually was interested in what might be some definitions around innovation. And essentially the Wikipedia, because that's where I go for all my information, is the definition that they had was a new method, idea, or device. And to me, that didn't seem to quite hit it, because I asked the question, well, if a new idea or device is an innovation, then what's the difference between an innovation and, say, an upgrade? So is it just about something that is being new, or what is it that makes something innovative? So digging a little bit deeper, one of the things that they said is that it actually needs to meet a new requirement. It needs to address an unarticulated need, or to actually address an existing market need. And it needs to help break into new markets or society. So for me, I thought that this was very interesting, because innovation is not just about the upgrade, but it is also about the end user and how the end user uses that innovation, and what does it mean to them, and how does it impact for them. So with that as the sort of shared understanding that when we're talking about innovation, we're not just talking about something which is new or shiny or sexy, but something which actually is defined by the end user, I think that it helps us to have a discussion today about innovation. So with that as the backdrop, I'm going to ask each of our panelists, really, what is it that innovation is for you, and how does it fit within the current context of your work? So Dave, you want to jump in?
Sure, thank you. First of all, thank you for the introduction. I'm really delighted to be at my very first ARM, so thank you for having me. I thought I'd start actually with a little bit about my journey, and then to take on this question of how innovation fits with our work. And so I'm a primary care doctor, but I really came to medicine and healthcare with a public health heart. And the reason that I say that is because of two early formative experiences that I had. The first was with a student organization, a nonprofit known as Universities Allied for Essential Medicines, which took on the problem of improving access to medicines in developing countries. And it was through that work that I realized that innovations like antiretrovirals are necessary but not sufficient for improving health. We also had to focus on access and the spread of innovation. And then the second formative experience that I had was working at the Louisiana Department of Health, where I focused on health system improvement and redesign both before and after Hurricane Katrina. And it was through that experience that I took away that people who are already living on the margins of our society are the most likely to become further marginalized particularly during times of crisis. And so those two experiences kind of pointed me to the role that I'm privileged to have at New York City Health and Hospitals. We're the public healthcare system for the city. We take care of over 1 million patients across the 5 boroughs of New York. We take care of taxi drivers and restaurant workers and people who are living with disabilities, and our patients reflect the cultural and the ethnic diversity of the city. The team that I get to lead takes on the issue of trying to build the future state of our health system, and we do it around a concept of population health, which we define as a more proactive approach to addressing avoidable human suffering. So with that background, I thought I would just offer 3 brief points around innovation at the beginning of our session, and these have to do with need, spread, and scale. So first, low-income people, like the ones that the patients that we serve in our system, are both most in need of solutions to their health problems, but also most likely to be excluded from those solutions. So I hope in our dialogue we can think about innovation in the future with, for example, the 100 million people who are either uninsured or on Medicaid at the front of our minds. The second point is in thinking about the spread of innovations. I remember very vividly when I was a medical student, I got to accompany our liver transplant team on an organ transplant flight. And I was so struck by the sophisticated teamwork, the complex orchestration, not just for the transplant surgery itself, but also for all of the perioperative medicine involved. And I think we should take a similar sophisticated approach to transplanting delivery system innovations. And the rationale for this is simple. We have too many proven programs, things like the Diabetes Prevention Program or PACE or the Nurse Family Partnership, which have not actually achieved scale yet. They have not spread enough. And I'll just give one example from our own system, Health and Hospitals, where we're trying to implement a delivery system innovation known as eConsult at scale as well. And it requires a balance between the need to maintain the fidelity of the intervention, which is all of the factors that led to the efficacy of the program in the first place, with the adaptability of the intervention, which takes into account the local context. And so finally, I wanted to end with a word on scale and ensuring that innovations reach those who are hardest to reach. In medicine, we often talk about seeing patients, when we're making rounds on the wards or when we're seeing patients in the clinic. But I think we equally need to have a focus on the patients whom we do not see. And that is what's required to try to make a difference with respect to innovation at scale. This can be for many different reasons. It can be for racial discrimination, because of fear related to immigration status, or simply because people don't interact with the health system unless there's a crisis. For example, the 13 million people who have high blood pressure but go undiagnosed with respect to their hypertension. And I think one way to address this is to start with those elements of our world, the things that already surround us that are at scale already. You could think of it as kind of like wind before there were windmills, and start there. And so that's one example that we've used in our system as well to try to think about leveraging medical notes that exist at scale. Some of us might say already at too grand a scale, to try to better engage patients through a program known as Open Notes. So I wanted to start with those 3 ideas around need, spread, and scale.
Thank you, David. We're actually going to get back to this concept of scale, and I think particularly because ours is a research audience, I think many of us are thinking about innovations, but we're able to do it at the proof of concept level. But the real issue in terms of our ability to have an impact on healthcare is this concept of scale. So we're going to come back to that concept. So Portia, do you want to tell us a little bit about your work, your background, as well as then innovation within the context of what you do?
Sure. So I laughed when I got invited to be a part of your group today because I have a degree in MBA in technology and innovation management, and so you'd think that I might know something about this, and I struggle to identify, just like you did, Anne, what exactly is innovation? But what I could tell you is that I've been very, very, very fortunate to see many instances of innovation through my career, but sadly, not so many instances of effective implementation of innovation. So I would say that's one key thing that we need to always be mindful of, and I don't need to redefine innovation. We can all look that up, and you led us off with a great definition. But what I would say is that integration must be central to innovation. So that's one key point I would make with this. And then another couple of things that I want to say. I have a couple of big ideas that I noodle around when I'm thinking about innovation. The first is that the best innovations that I've seen happen at the intersection of systems, healthcare and education, retail and logistics. You could probably think of a local example that might encompass that. But that intersection of systems is really a place where innovation is ripe to occur, and something that generally catches us by surprise and sometimes disintermediates what we always used to do, which is kind of tricky when you're holding to some older patterns and beliefs and things like that. So the second big idea that I would share is that stakeholder engagement must be central, and involvement of the people must be central. I've had the good fortune to work with many people and advocates within the disabilities community, and we have a common saying that we take with us everywhere: nothing about me without me. And I think that that's really, really critical for anything that we're doing out there in the world with innovation. Is let's involve the people first. So then the third big idea is one of leading with equity. So I am also fortunate in that I am one of the new board members for a new foundation based in Washington State, the Group Health Foundation. It's a health conversion foundation, and we're just getting started. And fundamentally, our plan is to lead with equity, because we must close health gaps that are due to structural racism, homophobia, and other forms of bias. We've got to close those gaps. And so that's a fundamental area of innovation that I think we need to pay great attention to, and it really ties in with implementation as well, that we really, really need to focus on how we are implementing these in a fair and just and equitable way. And that will be so critical to make sure that we have an innovation success as opposed to an innovation failure, which simply benefits maybe a few people.
Thanks, Portia. So Bob, I'm going to ask you the same question in terms of your views and definitions of innovation, but where I'm going to be a little bit unfair is ask you within the current context, as well as then in your previous work, because I think that there's a little bit of a difference in terms of how innovation may have been thought of or appreciated, or maybe not. So I'd like to hear your thoughts about that.
Well, I'd say I'm not so sure it's all that different, but it'll be a fun discussion, I hope, about this. I tend to think about, we're stuck on threes here, and looking at Richard Frank reminded me in our days at HHS with Sylvia Burwell, our common boss, you could not mention more than three things. That was it. So I've got three dimensions to talk about. One is the innovation that's incremental versus the one that's disruptive. That's a spectrum. And it's obvious that incremental innovation is a lot easier than disruptive innovation. Yet what I heard my previous two speakers talk about was pretty disruptive compared to the way things are for reasons that I'm sure we'll get into. And so I think the world is full of incremental innovations now that, in a sense, can make the current scheme of things work even more efficiently. And then you got to ask the question, what about the current scheme of things? And that gets to the second dimension for me, which is innovation is typically talked about in the sense of business. And business schools, so you mentioned the term market. And, you know, this fundamental problem that we've had in health and healthcare, what do we mean by market? And on the one hand, you could say the market is the demand for services that are paid for. Or you could say the market is the needs of people for better health. And I'd say right now those two things are so far out of kilter in this country that it's dramatic. And part of what I'm saying when I'm wearing my Duke hat at the university, and Duke has almost perfected the fee-for-service healthcare delivery model. It's really amazing how efficient it is. Half the things that are called innovative by our young people are really things you would just do if the reimbursement system was aligned with what people need, but it's seen as disruptive to the current way that things are paid for. So that's a dimension that I think as people think about innovation really needs to be considered. And then the last is one, you know, it's a little surprised that technology, you know, ends up as being seen as the most innovative, but really I'd have to say that's like the minor leagues compared to the major leagues. I mean, changing a piece of software where the endpoint is what are people going to click on next is a pretty simple problem compared to innovating with human beings about their health. It's a whole different aspect. And so when I look at it, now the big change, of course, is the fourth industrial revolution, which we're well into now. You know, just to refresh people's memories, steam and water power, electricity, computing, and now this amazing merger of digital, biological, and physical sciences that we're well into. So we're even having meetings now at the Vatican, where I was 2 months ago, asking the question, if you became a virtual being for infinity, would that be good or bad from the point of view of the Pope? And I don't know, but you can begin to think about all sorts of different ways to think about disruptive and other kinds of innovations, because the digital era is built into everything that we do. When people ask, why do you have 1 foot in Silicon Valley, 1 foot at a university in the Southeast? We're living in a digital world. Google has 6 products with over 1 billion users per day. That's scale. But the problems in most of our country are stark right now, despite the fact there is no digital divide in terms of cell phones. So now that cell phones are attached to the cloud, your cell phone has the computing power that entire universities had just a couple of years ago. But people are using that information entirely differently. So I think the scale of innovation can almost be built in, but there is a lot at stake in the purpose for which the innovation occurs. And I think the previous 2 speakers, in my view, articulated a point of view which I would say is not the current point of view of our reimbursement system in healthcare. And it's something that as health services researchers and deliverers, we need to be very explicitly talking and thinking about. You mentioned the FDA. I would just argue, I was a little kid when this happened, but we had polio, and iron lungs were getting better and better, and then a polio vaccine was developed. That was pretty innovative, and it changed the whole world for a lot of people. And I would just say within the FDA, there is a very strong view that FDA is not a finite thing in a box just for medical products companies to develop the next product, but it operates under a set of rules which hopefully enable people to develop the way you described innovations, I agree with. To be a real innovation, it actually has to accomplish a purpose. And that's really, I think, what the FDA takes to heart.
I think that's actually an excellent point, because one of the questions that I had as I was thinking about this is innovation inevitable? Oftentimes, especially when you go to many of the tech meetings, especially you see the young techies who may not necessarily know that much about healthcare, but they develop an innovation, and essentially, in my view, they've created a solution and then go looking for the problem, rather than starting with the problem and then go driving towards the solution. So I think, though, that as I've heard from across the panel, when you're grounded in addressing an unmet need or addressing the needs of a specific population, then innovation is one way to address that. So I'd like to switch gears a little bit and talk about the concept of failure. And so first there's the concept of failure as a prerequisite for innovation, and then there's the concept of failing to innovate as you're trying to address whatever the needs or the challenges are. So within the context of your work, and I'll open it up rather than kind of marching through, can you think about examples from your work that really was an opportunity to attempt to innovate? There was a failure, but it actually led to a greater opportunity. And also think about times when there was a failure to innovate, and what did that mean within the context of your work? So I'll open it up.
I can
David.
start. Sure. Well, you know, the example that comes to mind from our work is the failure to innovate that exists at the intersection of physical health and behavioral health. And kind of the simple metaphor that I always have in mind for our failure in that respect is that it's as if, you know, one of the beautiful bridges here in Seattle, we had two different types of civil engineers, one for the parts of the bridge that were above water and one for the parts that are below water. And that's, you know, certainly for our system, and I think more broadly across the country, that is how we have treated physical health and behavioral health. And so we identified that a few years ago, and we thought about, you know, very concrete interventions that could try to link across those two fields that remained too disparate. And you know, one approach that we have now advanced at scale is implementing a collaborative care program, which brings behavioral health clinicians, generally social workers and nurses, into the primary care setting, pairing it with universal screening, starting with depression, but starting to move to anxiety and substance use disorder as well, to try to address the needs that patients are already presenting with, but which were going unmet. So I think that's one example where we saw a very clear failure, where a relatively simple innovation was able to address it.
Thanks. I think, was it Portia or Bob? You were going to say something?
Yeah, I have an example that I would share, very different than yours, Dave. I have done quite a bit of work in the financial industry, and if you know any bankers or you know, advisors, they're pretty conservative folks in terms of being risk averse, particularly banks. I mean, you certainly don't want to lose your depositors' assets through some sort of a inappropriate action or anything like that. But this is a systems failure to innovate is what I'll talk about now, and it involves marijuana. Okay, so in Washington State, what was it, 3 years ago now, maybe? I can't remember. I actually don't use marijuana, so this is theoretical. So we passed a law in our state that recreational marijuana is legal. So super, great. So the people who choose to use marijuana as an adult can do that. But what happened was we failed to create a business system for marijuana sales, retail sales. I mean, we certainly had plenty of regulations and plenty of, you know, you can't be too close to a school, and you have to be, you know, just the large list of things that the businesses had to go through to get set up was astronomical. But the last mile problem in this instance was banking. And the last thing that you want to have happen in an environment where you're selling marijuana that has been illegal in the past and is currently brand new legal, is you don't want to set up a system where you invite a criminal element in to manage that brand new emerging system, okay? So we essentially, because our financial institutions, for many, many reasons, were generally unwilling to step up to the plate and do business banking with our new businesses, it became a real challenge and a real problem with cash-based business. And you know what happens in cash-based businesses. There's an element of criminality that engages, and I'm not saying that our marijuana businesses in Washington state are rife with criminality. We do have a few credit unions and a couple of options for business banking, but it's very, very difficult and very hard. And so being risk averse and failing to take a step towards an innovation, and really, frankly, it wasn't even an innovation, so I guess I'm stretching the definition of innovation there a little bit, more focusing on the risk aversion problem of how we can fail grandly by not having the ability to step up and do the right thing. And so now what we've got is, how many states do we have? 11 at least states that offer recreational marijuana in a legal environment, and federal regulations and attorneys general who say that it's really bad and we're not going to support this, and and so we've got kind of a no movement and frankly a big hot mess right now. So so there's an example from outside where regulatory pressure at the federal level conflicted with pressure or changes at the innovations at the state level to create a real challenging environment that we're still not, we're not out of it yet. We're not out of the woods.
Yeah. Bob, do you have any comments on that?
Yeah, a few, but let me just say, it reminds me of a really fun hour I had as FDA commissioner trying to talk down our field agents in Denver from impounding all the marijuana in the state of Colorado, because it was legal in Colorado, but not legal in the country.
Yeah.
But as you know, there was a policy that said just let the states do their thing. Anyway, didn't go over too well with some of our field agents at the FDA. But I'd make, first of all, the biotech industry is designed this way. 90% of drugs that enter phase 1 don't make it to market because they fail, and that's just an accepted part of the business. It'd be nice if it was a little bit higher success rate, but that's the way it works. And I could name 100 examples of how that's been useful, but just a recent one that comes to mind is we need better drugs for hypertension and heart failure, and it seemed that combining two drugs, an ACE inhibitor and a neprilysin inhibitor, would be a big advantage. In the human trials, it turned out the combination of those two caused an exacerbation of angioedema, which is a lethal problem, particularly in African Americans. So that drug never made it to market. But seeing that problem led to substituting an angiotensin receptor blocker for the ACE inhibitor. Voila, you have a new drug that's been tremendously successful that lowers the mortality in heart failure without that problem. But that's a characteristic of a system, like I said, about the FDA and industry interaction, which is built on the expectation that failure will be the norm, but you'll learn and pick from that and then adapt and do something better the next time, but still empirically test it. Just for fun, let me mention, I think if we then go to healthcare delivery, for some strange reason, we've decided that's not the way we're going to do it. We're going to let eminence-based practice dominate over evidence-based practice, and we rarely do experiments, which is the most rapid way to learn. Yet when you log on to Google search, you're participating in an average of 3 randomized trials every time you do it, because the tech industry wouldn't think about changing something so important based on opinion. It wants to know the answer, and randomization is the fastest way to get to the answer. For some reason, we're not doing that. And I would put forward that we are presiding over one of the most catastrophic failures in the history of our country with our healthcare system now. Mortality rates going backwards for the third year in a row now underway. So we have a failing system that we're in charge of, or at least studying. And what are we doing to learn from that failure and change what we do?
Yep. So I'm glad you raised that. And again, as most people who talk about innovation talk about that, we need to have a culture within the context of where we work, where there is an opportunity to accept failure because you need to do it in order to move forward.
Can I say one thing that's just
Sure.
bugging the heck out of me right now? Because I've, one advantage of being in the alphabet environment is just about everybody comes and talks about what they're doing. And I would say one of the most important places where failure is not accepted right now is reporting statistics from health systems. How can it be we have a country where it seems like 100% of health systems are reporting better results, and yet the country as a whole is getting worse? Those things don't add up to me. There's something about not being able to admit that you're not necessarily doing better that's going on here.
I think that gets a bit to what David was saying in terms of thinking about where we see our patients and where we report as compared to where health actually occurs. So one of the questions that we ask to the audience is, what do you need within the context of your current environment to help promote innovation? So I've heard all of you really talk about this acceptance of failure, but one of the things that we've seen here is that failure definitely comes up, and I don't know if the results are being projected for the audience to see. But they've also talked about better collaboration, funding, leadership, support. And so in general, there is, I think, a strong cultural need in order to help promote innovation. So there's this issue of addressing the problem, and then there's this issue of then having a culture where then people are able to innovate in order to address that problem. So then let's say we have all of these elements set up. So you have the problem, you understand that there's an ability to address it, you come up with some new ideas, you're in an environment that accepts failure, that accepts opportunities to try something new, and then you have this innovation, but then what are the opportunities to spread? And I think that this is actually particularly important for our field because many of us are in academic environments where we may do small scale innovations, but part of the relevancy for our work then is the ability to really take those to scale and then to take them to scale in a variety of very different settings where you may not have the same kind of control that you have under experimental conditions. So many people I know are familiar with the work of Rogers and Diffusion of Innovation, but there's sort of that theoretical work and then there's the real work. So can you talk a little bit about then taking it to scale and really spreading innovations within the context of your work?
Sure, I'm happy to start again.
Go, Dave.
Maybe I'll start actually with an example that connects something that Rob was talking about with respect to the biotech industry as well as our delivery system. And the example is direct-acting antivirals for hepatitis C. These amazing curative therapies that have been brought to market in the last few years. But we look at whether or not they have scaled and have actually, met patients' needs. And we're confronted with the fact that in the United States, the vast majority of people who need those medicines are actually not accessing them right now. In fact, there are, I believe, 9 countries around the world that have stated their intent to eliminate hepatitis C by 2030. It includes Mongolia, Egypt, the country of Georgia, but the United States is not among them. And so I think this lays bare, a little bit of what you're talking about, which is how do we take innovations that we know work and actually get them to people and get them through our system in a way that confronts some of the failures that exist in our system. And I certainly don't have all of the answers, but just one to, for us to maybe think about is to invoke innovation and prize innovation, not just for things that are generated de novo, but to put as much care and design into that question of diffusion and spread, just like the transplant surgeons that I was mentioning earlier, and actually have people truly focused on that process of spread.
Others?
Well, I think we have a built-in mechanism for immediate diffusion of any idea now with the spread of the digital environment. And so, I just reiterate, I really have increasingly felt strongly that the focus needs to be on the payment system. If we don't fix that, any spread of innovation is going to be going upstream. And if we do get it aligned, it's not that hard for the information about what to do to get out there. It's just we have barriers. On the academic side, I do feel like I need to get in my little lick about the academic thing, and I am one. But, hoarding ideas by academics is still a big issue. And until we get a point where we can more freely exchange the ideas, not protect them so much, it's going to be hard for diffusion to occur in this arena as much as it needs to.
I would agree. So
I
go
could
ahead.
address this too a little bit. Let me start with two stories, one from education where I have seen successful innovation occur recently, and then one involving Alzheimer's where we struggled to develop some innovations. So in education, the structure of education, at least in Washington State where I work, and I'm talking K-12 education now, is such that we have almost like a pathway to innovation that we're using now. We have educational service districts, and they support a geographic group of school districts. We typically have subject area leaders dispersed from around the state. I'm sorry, not dispersed around the state, but from around the state who help with spreading information. So we use a kind of a deliberate implementation science to convey good ideas, proven ideas in education. And we're seeing our adoption cycle go from 7 to 10 years for a good idea down to 1 to 2 now in Washington State with with our state K-12 public education structure. So that's pretty exciting. So structure matters in terms of diffusion of good ideas and how we do that. One other thing we did that was a success factor in education is that we actually reached out to teacher leaders and worked with teacher leaders to help them develop skills and knowledge in implementation science. So they became better at that, and that was also very helpful. So a little meta thinking sometimes goes a long way. Let me contrast that very quickly with another story, another group that I worked with, the Alzheimer's disease working group, a state government-sponsored initiative to address our pending anticipated needs in terms of people who are going to be experiencing some form of dementia as they age, and recognizing that our state had nowhere near the number of resources or the resources necessary to support people who will be experiencing that issue. And so we had a number of researchers and health leaders and others focus on one aspect of support for people with dementia, and they were thinking about things like standard diagnostic processes. What should a GP do to help a person who comes in and says, "Doc, I think I'm losing my memory. I'm really scared. What are some basic protocols? What sort of simple clinical tests can we do, that sort of thing, before we refer to a neurologist, for instance. And think about rural populations versus urban populations and who has access to that sort of stuff. But anyway, suffice it to say that that was a huge challenge, because even with our health researchers and our physicians in the room with us, none of us really quite understood how we could diffuse those ideas to physician leaders and to physicians, GPs, other specialists around the state. And our state, I think, is kind of lucky. We have an organization called the BRIE Collaborative, and its purpose is to disseminate evidence-based practices. So even with that, we struggled very, very much to get information out to our healthcare community in Washington State.
That's actually pretty a good example of what happens across all of healthcare. So I want to make sure that we have time for questions at the end. And as you all know from the app, we have opportunities for people to submit questions and to upvote them. And so before we turn to the Q&A, I want to go to this concept of disruptive innovation, and particularly thinking about, Bob, the work that you're doing, as well as work of others. But I think particularly within the context of, because we are a research organization and because many of our members focus on issues of data, I was actually just reading a report from Ernst & Young, which was talking about data within healthcare. And the quote from that report is, "He who holds the data has the power." And so if we as researchers have data which might be hard to manage, or as you said, in an academic environment, we hold on to it, does that make us vulnerable when there's the other kinds of data that are out there from the Googles of the world or the Amazons of the world, as well as then their ability to turn it around to utilize those data and those insights for different types of audiences? So when we think about disruptive innovations, where might that come from? And then what does that mean for us as a field and for health services researchers? And so I'm going to call out Bob, but I invite responses from anybody.
Well, speaking for Google is as insane as speaking for a university or the federal government. It's a big organization, so I'll just speak for myself. I mean, I've always felt that information was power, and I still see evidence of that in everyday life, most places I go. So the big disruptor will be a digital world in which the information is available, because most people in our country and elsewhere want their information to be available for learning to make things better. We just are having trouble figuring out how to make that happen. But the sooner it happens, the better off we'll all be. But it will be disruptive to a lot of people, because much of the control of the finance and expertise of healthcare is part and parcel to withholding information and knowledge from other people. That's just my personal belief. It could be challenged and it could be wrong, but let's just say there's a mission. The funding of Google search we could have a long discussion about, but at least if you don't want to buy into advertising and purchasing things, it's free. Mm-hmm. And if you thought about healthcare delivery and understanding healthcare where the information was readily available, not just the 1% of your time you're in a clinic or a hospital, but the other 99% of your life where the data are now being collected routinely, imagine what could be done.
So I think that speaks to the need for us as a field to be able to innovate, to really bring in those different types of perspectives. Others on the panel?
Yeah, I'll make a couple of comments just from our experience at health and hospitals. And I have to give a shout out to Remley Newton-Dame, who leads the Data Core at Health and Hospitals and is here at Academy Health as well. A couple of things that I've learned from those colleagues. One, data moves at the speed of trust. And so the people with whom you have trusted relationships will help determine the power of data. We see that certainly within our own system with respect to questions of confidentiality and privacy and how they intersect with our ability to do more and more powerful analyses. And then the second principle, which will, I'm sure, resonate with this audience, is the idea that that data has to be actionable, and the way to do that is to bring it as close to the point of care as possible. It is just always remarkable to me how much conversations with technology companies or payers or other people who sit on troves of data forget that it doesn't matter how pretty the graphs are, if they don't show up in my clinical workflow when I'm taking care of a patient, precisely at the point in time when I need it, then it's unlikely to make a difference in clinical decisions or other things that really matter, when you're talking about hitting the ground and changing patient care. So
I want to object to one thing you said, but you've fixed it, at least in my opinion, with the second part of what you said. I think I'm learning in Silicon Valley that the way we treat healthcare data, the trust thing is a good aphorism, but the second element is utility. So it's not that people trust Facebook, but you'll notice that Facebook's stock just hit an all-time high after all the issues about breach of trust. People use Facebook because it serves a purpose,
Right.
and they're willing to give up a lot of privacy that they wouldn't otherwise do. And I think, but here's where I think you really fixed it. If you talk to almost every health, clinician now, they're spending inordinate amounts of time entering data into computers, and they're getting almost nothing back at this point. And the patients are also getting very little. So if we fix that, I think there will be a lot more.
I don't think Facebook will fix that, but I take your point.
Just make it easy. So, Portia, was there something
Nothing.
you were going to say? All right. So, the last question that I have before I turn it to the audience. So, actually, as I was flying here from Washington, I happened to be sitting next to Paul Meisner, who is the VP of Global Innovation from Amazon. And so, I was really picking his brain because I knew that we were going to do this session. So, for those of you who are tweeting Paul, Misener, at Amazon, because I told him we were going to give him a shout out from Academy Health. But one of the things that he shared with me is that he was actually recently invited to talk to the National Business Group on Health to talk about innovation. And so I found that intriguing that the National Business Group, which essentially represents organizations that purchase half of the healthcare here in the United States, would go outside of our industry to talk about innovation. So if you were next year invited to go and talk to the National Business Group on Health about innovation, and given what they have in terms of access to data, access to the people, access to resources, what might be some of the challenges that you would ask them to consider, and what might be some of the innovations you would ask them to consider?
The National Business Group?
On health.
Wow, okay. I'll call you all tomorrow and send you a text because I'm a contemplative person and I would need to reflect on that a little bit.
Well, I would just say they should consider a relatively existential question, which is, what would they see as the purpose of innovation? Because I think the tools we have now would enable the use of analytics, for example, to very much segment the population into those who are employed, doing relatively well, who can do better and better, given access to technology, versus those who aren't employees of their businesses, who right now are doing worse and worse in our country, specifically due to the way that we're using analytics. I just saw, I won't name the health system, but I just saw a very prominent health systems plan for where its oncology clinics are going to go. Elegant analysis using geospatial mapping and trends in financial and healthcare data. The clinics are going to go to the wealthy neighborhoods where the paying customers are, not where the need is. And so, I think the business community has an important question to think about: which direction are we going to go? Beyond that, I think it's Katie bar the door for technology and innovation now. I mean, it's just a wide open field where so many great things can happen.
Absolutely. I mean, I will say within the context of even the work that we're doing within my own setting, right now we're trying to understand issues of just seasonal allergic rhinitis. And we're looking at data through Google that allows us to look at clinical records, Twitter data, census data, all combined within one data set, and then you apply machine learning and is generating fantastic insights to really help us. So, all right, so with that, let me turn to some of the questions that the audience has. So one of the first questions is, how do we facilitate integration and collaboration so that patients have easy access to their own protected health information? So I think this gets to a little bit of some of the points that you were saying, Dave. So you want to take a first stab at that?
Sure. Well, first, I'm just heartened that this is, top of mind for so many people as well. I think it's, a topic that we haven't touched upon that much is the importance of patient engagement, which can be a buzzword in the same way that innovation, is a buzzword. But the core of it is really about elevating self-care and allowing patients to be more participatory and actually direct their interaction with the health system. And I think that starts, it doesn't end, but it does start with access to their own health information. Each of us has, real horror stories about the challenges of getting information to move from one part of the health system to another. And in terms of, how to facilitate it, I would look to the VA, where there are so many, underappreciated innovations. The VA advanced an initiative in the Obama administration called Blue Button, which really facilitated that transport of information. And I think to get to an analogous place more broadly in our country will require some challenging of EHR companies and others who are blocking that free flow of information right now.
So the next question, I think, Portia, this is really directed towards you. It seems like it really resonated when you talked about leading with equity. So we have a lot of people who are asking, what does leading with equity look like?
Sure. Well, let me share with you just a quick story from education so that you can see this. But essentially, it's reframing and rethinking how we're approaching information. So much of our work has been about separating out groups of people and then applying some numbers to them. In education, it used to be we had a large number of subgroups that we had data on, and we would report on that. And we called that the achievement gap, almost as if we were blaming the people who might not have scored at a certain level. So what we've done in Washington State under, actually I would credit Representative Sharon Tomiko Santos with this major push in our state, is we talk now about the opportunity gap. And just the same as race is not a cause, or your LGBTQ status is not a cause, it's the stress of living with racism, it's the stress of living with homophobia that may impact your health status. So it's a mind shift for starters. Those are just two tiny little things to think about as we're moving forward. We could spend days and hours and weeks undoing the hundreds of years of trauma that we've caused. But let's just start with a mind shift, and I'll leave it at that.
Important comment. So we're over time, and I will actually just very quickly rapid fire ask you, if you were Atul Gawande and you were taking over JP Morgan, Amazon, Berkshire Hathaway, what would you do? 30 seconds or less.
All right, so the easy stuff
No pressure.
Equip people at home with technologies and access to clinicians in primary care, so almost everything is taken care of, not using a clinic or a hospital at all. And get rid of the PBMs because Amazon can deliver drugs. Get rid of the insurance company because they're self-insured. You cut the cost by 30 to 40% right there. The only problem he's got is those darn specialists like me. So he's got to figure out how to negotiate with specialists for care, a place where Kaiser, for example, has done well in some regions and not in others. I think they're going to really show us that this can work, but they've got to solve the high-tech specialty component of it.
Okay. Innovation. Let's thank the panelists.